Okay.
Then I record on my computer or I record in cloud. I'll just record in cloud and then I via Dr. Intan put up on the Google Mail. So in Google Mail, have you all got all the videos? Have you
Yeah.
all know? Okay. So if you all have got, then it's all right. Okay, good morning, class. It's already 11 o'clock. I know you guys are very tired, but so am I too. So we'll see how we go. This 2 hours lecture in the morning, late morning, and then 3 hours later is practical in the afternoon. Um, Today is on the 17th November, so we're going to be learning about auscultation, diagnostic imaging. Radiograph itself is going to be more like a revision, and then I'll expose to you about echocardiography. Okay, so later in the afternoon, I've already put up what we're going to do later and the duration of time of the activities also as well. So we'll be doing this together lah. And I've already put up all those cases later that you're going to view. So explanation later, I'm going to give it to you all. So these are your group numberings for the activity for the practical later in the afternoon. Okay, so let me stop sharing this one and okay, what am I supposed to do now? Okay, so what we'll learn first is we'll first learn. Okay, so tak boleh macam ini. And I need to see optimize motion in video. Can see screen, correct?
Yes, I do.
Okay. So what we're going to do for now is going to be cardiovascular system. And what we're going to learn today is going to be auscultation. My stethoscope is here with me. All right, every one of you, you have your stethoscope, correct? And this is going to be your buddy throughout your clinical years. Okay, so this stethoscope is very important, like what I say into your respiratory lecture, that you're going to be hearing lung sound. And beside that, auscultation of the heart is very important because when you're able to detect abnormalities of heart sound, then you will then come up with a problem list and differential. So that's how I'm going to guide you today. Okay, now you will need to identify how to use your stethoscope properly. Okay, so you have your ear tips, all right? And then with the ear tips that you have, you can, in your stethoscope, you'll normally notice that, the angles are actually very different. So you need to use the ear tip. This one is actually pointing into your ears, not the opposite side. Okay, you cannot hear when you turn it around, but this one needs to fit in real well into your ear opening and aiming directly to the canal. All right, if these ear tips are not placed into the ear properly, dia longgar lah. Okay, so it's a bit loosened, then you might not even pick up heart sounds properly also as well. So you need to get it fit properly. Okay, so then you have your ear tubes. Now, these ear tubes may vary for different practices. Perhaps sometimes panggil apa, for horses and stuff like that, they may look a little bit different. Okay, and then tubings for horse work tends to be longer also as well. But I guess in Malaysia, you don't have anything which is much longer lah. So whatever that the human practices use is already sufficient. And the diaphragm. Okay, now you will notice that if I see you in rotation, on every Thursday and stuff like that, I have got a smaller diaphragm. Okay, because I do a lot of works with cats. So this smaller diaphragm is actually much more better for me. A bigger diaphragm will actually fit better for dogs lah, and especially large breed dogs. So the bigger diaphragm is the one that is being used commonly for human one. No? So this one is actually used for infant or pediatric. These are actually baby's stethoscope. Simply because heart size for a cat, the size is actually as big as their paw. Okay, so cat's paws are very small. So I would want to listen to the valve properly. Okay, I would like to listen to the valve properly. So let's say if I've got a very big diaphragm, just ignore my dogs lah. If I've got a very big diaphragm, I will pick up a lot of other noises also as well. Okay, so for students, your big diaphragm is sufficient now for now. Okay, so stethoscope, you just need to know how to use it properly. Okay, if you put it on the wrong place, if you put it on the tummy, you're just gonna hear the gastric juice. And if you're hungry, definitely you can hear the gurgling sound. But those findings are actually not important. Okay, if you put it on somebody's hand, then you can say, oh, I didn't get any heartbeat because you're just using it wrongly. Okay, so please don't do that. Practice appropriately lah. Now that you're in surgery rota, you get to hear heart sounds, you get to hear lung sounds, but you just have to practice them properly. Dogs. Let me just close the door. Okay, my apologies. Can you all still hear the dogs?
No, doctor. It's
Okay.
fine now.
It sounded like I came from a shelter. Okay. There are 3 dogs in the neighbor and I have mine, so they are like a policeman outside. Okay, so where's the heart? So where's the heart? You know where's the heart? But more importantly, in your anatomy class and your physiology class, they have already created an awareness. They have already taught you where is the heart. So you need to know where is the location. And when we listen to the heart, normally we will want to know the heart sound is coming from the left side or on the right side. Okay, it makes a lot of difference because different valves are located in a different side. Okay, then after that, more terminologies that I'm going to expose you today is where is the base of the heart and where is the apex of the heart. So B is base, A is apex. Right. Base of the heart is often here. You know that the heart lies between the rib, the thoracic rib of 3, 4, and 5. Okay, so this part is actually the base of the heart, and this part is the apex of the heart. Okay, so we have the A. So when I auscultate, normally if I take away the B and A, I normally move my stethoscope from the base to the apex on the left side, and then you go over to the right side from the base to the apex on the left side. So what you need to do is you just slide. Okay, so when you auscultate, what you need to do is you just slide. You hear good lap dubs. Oh, okay, I could hear heart sound. Then you slide further down, and then you go up again, you come down again. Okay, I've got good lap dubs. I didn't, get any abnormality. So then you change side. All right, so that's what you're going to do. So normally I won't listen to heart sound. Look at their rates and rhythms just from one side. If I just want to calculate heart rate, that's fine. You can just listen from one side. But if you are picking up abnormal heart sound, like murmurs, then you might want to switch side because different location give you different location of the valve. Okay. You all can stop me if you suddenly do not understand. So when we listen to heart sound, normally I look at the dog, I know where's the location, right? But I don't, straight away put my stethoscope there, okay? Often I would want to place my palm over on the left and on the right axilla, and then I want to identify for any trills, okay? Trills sounds like excitement, isn't it? Thrill sounds like happiness, isn't it? Thrill sounds like, yay, I'm going to do something. But unfortunately, for cardiac auscultation, that's not the meaning for thrills. Thrills are actually, when you put your phone on vibration, when somebody call you, it will vibrate, correct? So you put it on mute, isn't it? Right? It will just vibrate. So when people call in, will give you that zzz, zzz, correct? So that's how actually trills feels like if the heart has got a murmur. Okay, murmur equivalence to regurgitation. All right. So if there's a trill, then great. If there's no trill, never mind. I'll teach you how to grade the murmur later on. And this trill is actually very important description. Okay. So after that, you can actually feel, the entire chest. All right. You feel for the apical beat. Okay. Then only you put your stethoscope over the apex beat, and then you listen for your lap dub. And then you count the heart rate. And as you count the heart rate, then you evaluate the rhythm. Is this lap dub regular? Is it regularly irregular? Or is it irregularly irregular? Okay, which I'll explain a little bit more later. Okay. And then after that, you want to hear that, is there a murmur? All right. And where is the location of the murmur? And you move your stethoscope cranial dorsally and identify the intensity of murmur. Which location is actually the loudest? Is it at the base or is it at the apex? Okay. So you know the normal range already. Large breed dog tend to have a slower heart rate. Small puppies, small dogs, and cats tends to have a higher heart rate. All right. And you also know that heart sound, the Prof. Bob has already taught you that heart sound has got S1, S2, S3, and S4. S1 and S2 it refers to the laps and laps. And then S3 normally you jarang dapat dengar lah. S3 normally is like gallop rhythm, da da da, la da da, la da da, la da da. Or sometimes in S4 you get the horse having a slower heartbeat. You can have a very good differentiation of the S1, S2, and suddenly you get an S4. So that's only in horse. Okay, S4 is only in horse. Okay. Heart rhythms, you want to get them to be regular. Okay. Regular means lap dub, lap dub, lap dub, lap dub. Regularly irregular, it's lap dub, 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 lap dub. So you get good rhythms, then suddenly, why like that? Then after that, you come back, oh, okay, it sounds like a good rhythm, and then suddenly, you get a different beats. Okay, so that's regularly irregular, and respiration sinus arrhythmia gives you that. Okay, so respiration sinus arrhythmia is the one that I exposed you the term during ECG, isn't it? So that's what it means lah when you get regularly irregular. Okay, so it's between the respiration and inspiration, and it's because of the suppression of the vagal tone. Okay, now this one, I'll leave it to you all to read. What is S1, what is S2, S3, and S4, simply because this awareness have been given to you all lah when you were in your younger days in the early semester. Okay, so most important thing is remember S1 and S2. And if you get a gallop rhythm, which I demonstrate just now, la da da, la da da, la da da, and if you hear it in dogs, okay, you email me, you call me, you find me, and you stop me, all right? Because it's not common. So if that happens, you could be dealing with a dog that is going to be having an early disease or coming into congestive heart failure. And a lot of time when you see or you hear this kind of sound, they could be having ventricular dilatation, okay, as a result of mitral valve insufficiency in dogs, all right? And in cats, it could be dilated cardiomyopathy, it could be hypertrophic cardiomyopathy. It does happen, okay? So it's abnormal lah if you get gallop rhythm, all right? Kalau you get respiratory sinus arrhythmia in cats, is it normal or abnormal? If you get regularly irregular respiratory sinus arrhythmia in cats, is it normal or not normal? Somebody answer me or not, I cannot move forward. No, not normal. Respiratory sinus arrhythmia only happens in dogs. It is normal in dogs, but if it is in cats, it's abnormal. Okay? Please remember this, yeah? Okay. When you are describing hard sounds, they could be transient sounds and they could be murmurs. Just now we listen to rhythm, we calculate rates, and then we listen to rhythms, and now we are listening to sounds. Like respiratory sounds lah. So heart also has got their own heart sounds. Okay? So if it is transient sound, example, if you get ejection sounds and systolic clicks, all right, both are actually high frequency sounds and they could be heard at the AV valves. Okay, and most likely sometimes it may occur with murmur, but these transient sounds are actually not very commonly detected. Okay, if you hear something like lup tup and a click after that, then you might want to really hear it again. It might be there truly or it might not be there. But if you do pick them up, it could be due to valve prolapse or distended of the left ventricle, or perhaps maybe the cordia tendineae has already snapped. Or some of these dogs, they had valvular dysplasia in some breeds. And when I say dysplasia, often this is a congenital disease. Okay? When you hear murmur, murmur means they happened because of turbulent blood flow. Okay, so just now I said trills, isn't it? That you could feel for vibration on the chest itself. All right, so when you auscultate, the description or the name is called murmur. Okay, um, vibration, so turbulent blood flow in the left atrium actually, when the normally smooth or quiet laminar flow is disrupted by alteration in blood viscosity, or there is a vessel's diameter that has changed, or there's an abnormal flow pattern from insufficiency of the valves, or maybe there's an abnormal communication between the cardiac chambers. Okay, boleh paham ke this definition? So meaning there's a flow destruction altered in blood viscosity. So blood viscosity sometimes can be referred to anemia. Okay, normally you would have a normal PCV, and now it has got an anemia because of some form of blood losing. All right, anemia can give you murmur too. Okay, that's what we call as a physiological murmur. Vessel's diameter, perhaps maybe you have a pulmonic stenosis, all right, or a aortic stenosis. You know the blood vessels has already changed in diameter and has already shrink in terms of the diameter. So you tend to have a regurgitation too. Or an abnormal flow, okay, because of the valves that has already thickened. Or maybe this patient has got a hole in the heart, interventricular septal defect, the patent ductus arteriosus. So you have, holes and you have shunts. You're going to get a murmur also as well. Okay? Okay. Describing a murmur, we need to know the intensity. Okay? We need to know the intensity. We need to know the timing. We need to know the location and shape. Okay? Which I will explain one by one lah. Okay. Intensity means how loud the murmur is. And murmur is being graded from 1 to 6. Okay? 1 means it's a very soft murmur. Sometimes you can hear it, sometimes you cannot hear it. So it's a soft murmur that is not immediately audible. But if with careful auscultation in a very quiet room, then yes, you can hear the murmur and it's so soft. Okay? For me, day 1 competency, I do not expect students to be able to pick up grade 1 murmur. And grade 1 murmur is also not very common to be picked up also as well. All right, I'm not going to punish you if you do not get grade 1 murmur. Grade 2 murmurs, they are just soft murmur. You can hear them. Oh, it's so soft. All right, I can hear them. Okay, this side, then after that they hilang, then I come back. Okay, I can hear them. All right. Grade 3 are moderate murmurs. Immediately you put a stethoscope there. Okay, I can hear them. Then grade 4 are like, oh, this murmur is very loud. All right, the difference between grade 4 and grade 5 murmur is grade 5 murmurs have got a palpable trill. Remember what I mentioned just now, a trill? So when you place your hands left side, right side on the dog's chest and you could feel vibration, then that means there's a palpable trill. And definitely for sure, when you get a palpable trill, you definitely get a murmur, and that would be grade 5. Okay, grade 6 is tak payah lah. Normally, grade 6 murmur, it's dogs which are already very cardiac asphyxia. You put your stethoscope there, you definitely hear the murmur, and you could even get the trill, not a problem at all, and it's so easy. And some OCD pet owners or dog owners who have got their own dogs which are having heart disease, they can even tell you, doctor, if I put my ears on at the chest of the dog, right, I can actually hear vibration. Okay, so that's what it means. Audible murmur with stethoscope slightly held off the chest wall, right? Often I won't even bother to actually grade number 6 lah. And often if grade number 6 is already at the chronic stage, it's already at the progressive end stage of the heart disease already. Okay, so grade 3, grade 4, grade 5 is actually very important. Grade 6 is already, we know the chronicity of the case. All right, then you have grade 6. Okay, location, left or right, correct? Base or apex, correct? Okay, all right. So if it is on the left side of the heart, okay, you're gonna get your pulmonic, mitral, and aortic valve. Number 1, your aortic would be at the base. Okay, your mitral valve, number 4, will be at midway. All right, so we call this area apical. Your number 5, your pulmonic, will be almost to your base area also as well. So all this area is just right under the armpit, very high up. Okay, so PAN, left side. So what you're going to get on the right side? So you're going to get your tricuspid valve. And often tricuspid valve will be at the apex. Okay, so sometimes you can get your aortic valve here at the base on the right side. But for me, you just have to always remember, if you want to auscultate the tricuspid valve, go to the right side of the chest. Okay, when you describe a murmur, these are old school phonocardiogram. Okay, phonocardiogram means if you Google this spelling up, it's actually electrical wave detected from the body of the dog and convert them into sounds. So those were the days when we don't have echocardiography, things are not developed. So they came up with a phonocardiogram. Sounds very musical, but then they converted them into electrical waves, and that's what you see. So 1 and 2 is lapped up. So that's when your depolarization of the heart, you get your this 2 sound lah. All right, and then they then explain this sound as into like pansystolic. So if you have them as a square, you call them band-shaped murmur. If you have them in diamond shape, then you call holosystolic murmur. And when you have them is this long elongated rectangle shapes, which are slightly shaped in differently, you call them continuous murmur. And if you have this triangle, it's called as diastolic decrescendo murmur. So if those of you who has got backgrounds in music, you know what is crescendo and decrescendo. So they converted this sound into electrical wave and then printed them onto paper and then described them in this name. I'm not going to give you an exam to say, hey, if you see this, tell me what is the name of this holosystolic murmurs and stuff like that. No, this is not going to be in an exam lah. This is just an awareness that there's such thing called as phonocardiograms. Okay, so these phonocardiograms those days, you have your LUPs and DUPs. So if it is aortic stenosis, you see this shape, okay? Holosystolic murmur. You see this mitral regurgitation? Diastolic decrescendo murmur, okay? Diastolic decrescendo murmur, all right? This one can be just your pansystolic band murmur. This one, continuous murmur, or like that one, okay, PDAs. All right, so that's how they read it those days lah, your murmurs and description. Okay. All right. You tell me if this is working or not. I will just have to. Can you all hear? Okay. I want you all to put on your earphones. So the next couple of minutes are just going to be sounds, yeah? These are laptop. Okay, happy? Nobody's happy. Okay, systolic murmur. Systolic murmur often is from mitral and tricuspid regurgitation. You can have stenotic, aortic, or pulmonary valve issue, or if you have a septal defect. Can you hear that whooshing sound? Whoosh, 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 whoosh. We'll do this again. Okay, so you call this a systolic murmur. Okay. And let's say if it is a diastolic murmur, now the tips is to differentiate diastolic murmur and systolic murmur. Similarly, but this one is normally at the base of the heart where the aortic would be, right? This murmur is actually not very common, okay? So let's say if you want to lie to Dr. Khor and say, I will ask you, so what type of murmurs are these? Can you describe to me, is this a systolic murmur or a diastolic murmur? You can just lie to me, doctor, I heard a systolic murmur, simply, and I will trust you simply because diastolic murmurs are very rare to get it heard, okay? And the disease occurrences is not very common also as well, all right? So if you just want to say, doctor, this is a systolic murmur, blah, 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 grade what of what, and heard it over which location and at what timing, something like that. Okay, so I'm not going to fault you, all right? So I'll let you have a listen at what diastolic murmur sounds like. Here. Can hear ke?
Can
I'll do this
doctor?
again. Cannot differentiate, isn't it? With the systolic murmur. Okay, so for me, I don't mind if you couldn't pick up diastolic murmur. As long as you could pick up a murmur, I'm already fine with that. Okay, but you need to know lah, diastolic murmur is not that common lah. So when I ask you, you don't just simply blurt out and say, doctor, I heard a diastolic murmur. I'll say, wow, can I listen to it too? Okay, so a continuous murmur often occurs if there's a PDA, if there's a fistula, if there's a hole in the heart for this patient. The patient comes in with a very big heart and they look at you with a kitten face and a puppy face. You know, this is the congenital disease. Most common congenital disease is going to be patent ductus arteriosus. And if you get that, they will sound like this. You cannot get laps. You cannot get laps. One more time. So it's like washing machine, correct? So then we differentiate back what is the systolic murmur looks like. Okay, so can differentiate? Are you all able to differentiate? So continuous murmur like washing machine lah. Wush, 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 wush. Okay, tak dengar, tak pun tak dengar. But normally continuous murmur, young animal, systolic murmur. Okay, you can have in young animal because of congenital diseases and they have an inheritance trait to certain disease. Yes, you can have systolic murmur in young animals too, but they don't sound like continuous murmur. So that's how you differentiate. Okay, so we have done intensity, murmur grading, location, base or apex, timing, which means systolic, diastolic, or continuous. Okay, so when you describe a murmur, intensity, grade 3 out of 6. Point maximum intensity. Okay, point maximum intensity means which location you heard the loudest. So you would say at the left basilar, and it is a systolic murmur. Okay, so that's how you're going to differentiate. Now, don't forget about the lungs. The lungs are actually very important for cardiovascular diseases and investigation. And with heart diseases, normally you're going to get crackles. Last semester, I've already taught you how to hear crackles. Boys with long hair, I know some of you have, and girls with long hair. So all you need to do is to appreciate crackles would be like behind your ears. You rub and play with your hair. Okay, you just, mind like that, and you actually hear sounds, and that's what crackle sounds like. Hush would be just like, this is your hush lung sound. Okay, louder than normal. All right. Okay, so often in cardiovascular diseases, you get crackles and harsh lung sound. It will be pulmonary edema. You can have pneumonia also sometimes. Chronic bronchitis too. And if it is a dull lung sound, then you'll be thinking about pleural effusion. Okay, so is that all for this one? Sebab dia tak nak bergerak. Okay. All right. Let's move to location and timing. So if you get a left basilar systolic murmur, it means that the problem lies in the aortic or the pulmonic valve. Systolic simply refers to there is a condition called stenosis. So then your differential diagnosis will be subaortic stenosis, pulmonic stenosis, tetralogy of Fallot, atrial septal defect, and sometimes a physiological flow murmur, okay, which I means anemia, all right, for a physiological flow murmur. Ayo, I don't know why the dogs are so excited. They were so quiet this morning. Okay, so if you get atrial septal defect or a physiological flow murmur, you tend to have a low grade murmur, says grade 3 out of 6. So they are much more quiet. Okay, all this one, young people, semua muka kucing, anak kucing, anak anjing. Okay, these are all congenital diseases. Right? Again, left basilar, but it's a continuous murmur. The word continuous is already a keyword. Nothing but PDA. Okay, the rest of the other vascular abnormalities are pretty rare in small animal diseases. All right, any neonatals that you get, they are born poor with the heart, similar like human. A lot of time is always patent bacteriosis. Left apical, think about mitral valve. Systolic, thinks about regurgitation. Okay, and the differential diagnosis will be thickening of the mitral valve, or dilated cardiomyopathy, or a congenital disease where the mitral valve at birth for that little pups is already dysplasia, not well formed. Okay, or if they look very sickly, they have fever, they have septicemia, they have toxemia, and suddenly you pick up a murmur after all those fever event and infection and stuff like that, then think about mitral valve endocarditis. Okay. Right apical systolic murmur, right side heart, tricuspid. Systolic regurgitation. So again, thickening of the mitral valve. See, mitral valve so kepo. It's supposed to be on the left side, right? Sekarang sudah at the right side too. Okay, sometimes it does happen. Or a dilated cardiomyopathy. This deterioration was also like just now. So it happens also as well. You can pick up this murmur on the right side of the heart. Okay, but often if you have a young pups or something like that, then congenital disease on the tricuspid valve, and the valves are not well formed. They are dysplasia. Okay, and again, if there's any, cases that has come down with fever, infection, navel ill, your goats, they have your little kids, and then their navel, the umbilical cord, that area is not being taken care of. Infection has already occurred. They have some form of septicemia going on. Joints are all swollen and stuff like that. And this is very common in your caprines, and it's also very common in your bovines. Okay, but often these kind of diseases are never picked up lah, because nobody wants to investigate on a goat or a cow. Okay, but if you pick up, this would be one of the differential. All right. And in another one more congenital disease, you can have ventricular septal defect, and you will pick it up in right apical systolic murmur. So this is a congenital disease then. Okay. So you're gonna have a lot of fun with your stethoscope. Okay, if you have it at home with you, have a listen to your pet or dog. All right, and then you practice left side, right side, base apical. Okay, so do you all want 5 minutes before we move on to radiology lectures? Okay, 5 minutes, so 11, 40, what, 7? Go, toilet lah, apalah, buat kopi lah, buat teh lah, something like that, and I'll start on time. I'm not going to wait, so you pandai-pandai.
Okay, doctor.
All right. All right. So is it, yeah, it's 11:47 already. I promise I will start promptly on time. Are you guys here? Can you hear me?
Yes,
Yes,
doctor.
Okay, unless I make a boo-boo, I unmute myself. All right, so radiology, cardiovascular radiology, it's more of like a revision. So you all shout out if I ask questions so that we can go faster. So it's more like a refreshing course from what you had last semester. Some of the things are actually similar. Some things I focus a little bit on because Dr. Lau cannot teach you everything. So we give a little bit focus over here. Okay, anatomy is very important especially for a surgeon and if you want to be a surgeon one day. So you need to know where the bones are, where the soft tissue are, and especially where are all these organs in within the body itself. Okay, so for me, I'll never do diagnostic workout for a heart disease without a radiograph. Radiograph is my number one first thing first that I will do. Once I pick up a murmur, radiograph. Once I've got a arrhythmia, radiograph. Okay, I will never do a radiograph before any ultrasound. All right, I need to know roughly what is the issues that I'm facing. Okay, before I proceed with diagnostic imaging of ultrasound. Okay, so to me, radiograph is the most essential tool. All right, no case is adequate studies without it. But I have a habit. I don't care even if it's going to be an abdominal issue, I will still go for radiograph first. Okay. So for the thoracic region, so this radiograph, what kind of information does it provide? It tells you how does the heart look like, big or small, right? It tells you what does the shape looks like. Okay, remember Dr. Lau would have mentioned things like Valentine heart shape, inverted D, gallbladder heart shape. Okay, the heart position has the apex switch. Okay, we learned this in ECG and we talk about mean electrical axis, have the apex of the heart switch. Okay, what is the position of the heart now? All right, definitely not upside down. That's never going to happen. Okay, but is it an inverted D? Is it a left-sided heart disease or is it a right-sided heart disease? Is there an overall bulge in any side of the location of the structure of the heart? Okay, then we always look at the lung. Heart and lungs are best friend. The heart is not happy, the lungs is going to get it. The lungs are not happy, the heart is also going to get it. Okay, so when you fight with your best friend, you're not happy, your best friend is going to get it. So similarly, this is what's going to happen. In any cardiovascular diseases, I will always look at the pulmonary parenchyma. I will also look at the pulmonary vasculature. Okay, then I will also look at the pleural space. All right. Okay. Now, when I take a radiograph of the thoracic cavity, let's say if this is a cancer disease, I'm sure, Dr. Lau would have mentioned to you, you will want to take 4 views. Right side down, left side down, DB and BD view. Okay, so this is just a revision. For me, you need to do a thoracic radiograph, a DV view, and a right lateral recumbency is already sufficient. But most important thing, you need to cover the entire chest from the first rib to the caudal part of the first lumbar vertebrae. All right, so from here to the last caudal, to the first lumbar vertebrae, you have to remember the positioning. You can do right lateral, left lateral, but for me, always the keyword is Dr. Khor is always right. So many things are presented on the right lateral recumbency. Okay, and I would just want a DV view. All right. So I wouldn't want a VD view because VD view is a very good investigation for the lungs. But for the heart investigation, I want a dorsal ventral view. Okay. And when you take the particular radiograph, in humans, they temporarily, ask you to change into another clothes. All right. Then after that, they will ask you to stand properly. But in animals, you have to position them. But before you click to get the image, you need to you will have better information if the lung, if they are in a fully inspiratory phase. So when they inspire, the lungs will be fully inflated. You get a better investigation. But obviously, in cats and dogs, you can never ask them to, okay, you stop breathing. All right. In humans, it's a little bit different. They will say, okay, breathe in, hold your breath, hold your breath. 1, 2, 3, wait, hold your breath. Then only they click. All right. So you just have to remember lah, there are limitations if you have them at inspiratory phase, but we'll go through that one a little bit in a little while. Okay, positioning. All right, lateral, often right side is enough. If I needed a little bit more, I'll do the left side, but right lateral recurrency and the review. Okay, so this is the lateral radiograph, isn't it? And you know, the heart position is going to be here. All right, third to around 7th intercostal space. Okay, you can see the heart. You can see the vasculature. Okay, one major blood vessels, which is the aorta, cranial vena cava, caudal vena cava. You have your blood vessels, your arteries and the vein. Okay, you can see your lungs, all nice. Radiolucent or radio-opaque? Radiolucent or radio-opaque? Black means what? Radiolucent. White means you get radio opacity. Okay. So now that you have seen this, now let's go to cranial vena cava, caudal vena cava. When you draw the heart in the systemic diagram, you know this is going to be the aorta. Aorta. Okay. So when you draw a line from the apical, from a line from the base of the heart, that's what we call the carina, and put them to the end of this part of the heart. So you draw this line, theoretically, normally you tend to have right-sided of the heart information more than the left side of the heart. Okay, so if you put them into 5 parts, then 3 out of 5, you're going to get all the right atrium and right ventricle. So meaning right atrium, right ventricle, left atrium, left ventricle. Okay, so that what it means lah, huh? Okay, when we look at the heart on right lateral recumbency, we always want to say, you know, this is going to be a big heart, but we need to scale them. We need to give them a score. So it's called as a vertebral heart score and developed by Buchanan and Butler. So there is a paper for this one where these two investigators came up with a score to actually tells you that, you know, is the heart big or not. If it is big, then it requires further investigation. If it is not, then don't do anything about it. Okay, so screening purpose, this is very good. This one Dr. Lau taught you already, can how to do a VHS? Yes, no? So is you want to see the heart size, you measure the A or the B, so the red line and the yellow line, and then you put them parallel to the thoracic vertebrae, and then after that you measure, so the normal average will be 9.7. Okay, but for small animal, when you want to say whether they are big, small, or okay or not, you see you have a plus minus of 1.0. So often, if you get anything more than 10.5, you need to think about it. You need to investigate. If there's going to be a mild enlargement of the heart, it's going to be 11 to 11.7. If it's moderate, then it's 12 to 12.7. So these are all very big lah. And if they are very big and huge, I never seen one that has gone up the size of 14. Okay, that would be very scary, but I have not seen one. All right. So they do define them, the cardiomegaly, as in mild, moderate, and marked. Okay, now this one, I bet she didn't teach you all, and this measurement only came out last year. Okay, so just now we calculate the VHS. Okay, these two measurements, put them parallel over here, and now we will measure the vertebral left atrial size. You know that the left atrial sits here, correct? So what we're going to do is we put a line from the carina, okay, to the caudal cranial vena cava sits here, caudal vena cava, on top of the caudal vena cava where it transects the heart, okay, this location. And then you bring up this line and similar like what you did for the VHS, you compare with the thoracic vertebrae, okay? So the median value of V last is actually 1.9, and the reference interval that they have already reported is actually 1.4 to 2.2. Okay, so this is the paper that recently it was published, say maybe about 2 years, and it's still being heavily investigated. Okay, clock face analogy is also very important because you want to know the bulging, which part of the heart is actually bulging and which structures is actually affected. Okay, so you put your clock face, jam muka tangan, onto the radiograph. So you can imagine this is 12 o'clock, this is 3 o'clock, this is 6 o'clock, this is 9 o'clock. You know this is the right atrium, right ventricle, left atrium, left ventricle. And you know if there's a bulge here, it will be the aorta. Okay, so now do you understand? Right? I'm sure this one Dr. Lau also taught you all, correct? Yes, no? Yes, I'm just going to move on. Okay, blood vessels, always remember artery, vein. Artery, vein. Okay? If it is DV view, right side heart, left side heart. Normally, you have some good space lah. Okay? Right side, left side. From the right side of the heart to the ribs. Okay? This is just very simple. And then you put your clock face analogy. We drew them. And then after that, this is what you're going to get. So you know this is going to be your aorta. Your pulmonary artery sits here. Your left auricle sits here. Your right auricle, your right atrium. Okay? Your right ventricle sits here. Your left ventricle sits here. So if any of this structure has got a bulge, you know that the problem lies within that particular location. Clock face analogy. Again, that's what you get. Aorta tadi sits here. Your pulmonary artery sits here. Your left auricle sits here. So sometimes if you get a very big left atrium, you can see a carboid stance over here. So left atrium slightly elongated until like that. Okay, it covers this location. So you can get left atrium here also as well, but this is the left auricle. Okay, so left ventricle, right atrium. Okay, so nothing different from what Dr. Lau is teaching, but this is like refreshing back. Okay, so blood vessels, and not very clear here. This is one blood vessels over here. Okay, this is another blood vessels over there. All right. Okay, felines tends to be a little bit different. Cats never follow rules. Cats are the naughty one most of the time. They often give you images that are very different, but you have to remember how does the cat radiograph looks like, the thoracic, the lungs, and the heart. Okay, the blood vessels, your arteries and your veins, cranial vena cava, caudal vena cava. All right, and they do have the VHS also as well. So similar like this one, this is a normal one. Okay, and they do have a range, mildly and large. Just now, the dog one I say it's more than 10.5. In cats, if you get a measurement of 8, means it warrants investigation. Okay, and that paper has been published by Gulameli et al. I think maybe about 5 to 6 years ago. Okay, so normal VHS for a cat is 7.5 plus minus 0.6. But I can tell you that cat's radiograph are actually not very specific for disease investigation. If you get it big, there you go, investigate if you think the VHS is more than 8. But if the histories, the physical examination still points towards a heart disease, there is one disease whereby it will not tell you that the cat has got a big heart, and that would be hypertrophy cardiomyopathy. Okay, I repeat, hypertrophy cardiomyopathy. So I'll teach you this one when we talk about diseases later on. Okay, if you have got a right-sided heart enlargement, these are your differential. If it's pressure overload, there you go, the congenital diseases. And you have volume overload, again, these are congenital diseases. Right side acquired, there's so many. Heartworm, Khor pulmonale, right-sided heart failure, secondary to the left-sided heart failure. You can have tricuspid, tricuspid, right-sided, tricuspid, right-sided. Okay, but again, you can have right-sided heart failure and hypertrophic cardiomyopathy, dilated cardiomyopathy, although often they start from the left side of the heart. But when the disease has already gone severe, then yes, you're going to have a right-sided heart enlargement too. Okay, then we move on. Right-sided heart disease, they tend to look like this. This position of the trachea is good or not? Correct or incorrect? Line. Somebody must answer me. Trachea. How do you describe this? Macam too dorsal. Okay, dorsally elevated. Alright, why? Because the heart is so big already. So we have got nowhere to go, so it pushes the trachea on top. Okay, so trachea pushes dorsally. So when you do a VHS, it's going to be very big. Okay, so when you put them and you count 2, 4, 6, 8, 10. Oh, 11. All right, echocardiography. Okay, remember when we say right-sided tends to be more enlarged, you tend to have more information on the right side. So if you put them into 5 parts, then you see that, hey, actually it covers more than 3 out of 5 of the parts that we learned about just now, right? It gives you a lot of information. Okay, right-sided heart disease, in a DV view, the description would be inverted D. The apex of the heart will be shifted, and if you do an ECG, the mean electrical axis, sometimes it may even shift to this side because the volume is more here. Okay, so sometimes it depends. So that's what it means by mean electrical axis for dog. So it may be shifted to somewhere here and it would be abnormal. Okay, inverted D, D terbalik. Right, apex of the heart also may be shifted, and you can see that the heart is more rounded. Cardiomegaly lah. Okay. If there is a pulmonary artery enlargement, can you see there is a bulge here? Yes, no? Aorta sits here, pulmonary artery sits here, left auricle sits here, left ventricle sits here. Yes? All right. Can you see something else in within the thoracic radiograph that, oh, what's that? And somebody can describe? Even if you don't know, it's okay. Even if you make a fool of yourself, it's okay. Jokes always make people remember more. Come, somebody? Or not, I minum teh Cina ini tunggu jawapan. The lungs have increased obesity. No, the lungs looks fine, but you know that there is an increased obesity and you don't know what is it. Come, another person try. Give it a go. There's obesity here, correct? There's obesity here. What is this structure? It's a foreign body, it's intestine. I'm talking about cardiovascular lah. Just now we learned about normal vasculature. I give you a clue already. Betul. Pulmonary artery. This is very typical. Tak ada hernia lah. Diaphragm looks fine over here. Normally, you want to check with another view, which is the lateral. Okay, this is pulmonary artery. So if you have got pulmonary artery bulge, and you have got blood vessels looking like this, top differential, tropical environment, heartworm. Okay, can you see another blood vessels here? All tortuous, enlarged. See the blood vessels are all moving like this. Okay, these are blood vessels, your arteries and your vein. Arteries and your vein. Okay, they are all very enlarged. Okay, Dr. Lau will always tell you, you compare with which rib? I cannot move on. Tells you compare with which rib? Rib number? Yes, this is a severe heartworm case disease. So when you want to know whether it's enlarged or not, which rib do you compare with in a very milder form of heartworm disease? Rib number 4. 4 is too high lah sayang. 1, 2, 3, 4, 9. Sajida is correct. Okay, rib number 9. You always compare with the rib number 9. So the diameter, then you calculate which one is rib number 9. For example, I didn't give you a good radiograph. So number 9, let's say number 9 is here. So this diameter you compare with this width of the rib. So enlarge lah. Not all the times you're going to have such a severe blood vessels. So you might have something which is smaller, slightly dilated blood vessels. Then you compare with rib number 9. N-I-N-E. In other words, 9. All right, let's move to left-sided. Congenital disease. Mitral valve dysplasia, PDA, ventricular septal defect, atrial septal defect, volume overload. Okay? If it is pressure overload, subaortic stenosis. If it is acquired disease, volume overload, mitral valve insufficiency, mitral valve endocarditis. If there's an altered contractility, hypertrophic cardiomyopathy, and dilated cardiomyopathy. Okay, HCM and DCM. Okay, so if it is a left-sided heart disease, you see, trachea dorsally elevated. The heart is too big already. But if you measure from the carina to the apex, from the carina to the apex of the heart, you tend to get more information over here. And you get a bulge on the left atrium. So if you put your clock face analogy, so 12 o'clock here, so 1 to 2 o'clock, you get an enlargement. So this is left atrium enlargement. Okay? So left-sided heart enlargement, you know, clock face analogy, all right? Your aorta, your pulmonary artery sits here, your left auricle sits here, and you tend to have a bulge here. Okay, so you know that's left atrium enlargement. And if you do a mean electrical axis, then you say, oh, the mean electrical axis is more like, towards 60. So you know that the apex would have already shifted also as well. So this one, there's a bulge over here. Okay, otherwise this is looking fine. Okay, if it is generalized cardiomyopathy, that's what you're going to get lah. Everything around, like a bola. Okay, everything around. You put your clock face analogy also, it looks like the clock face, all right? But very, very, very important is, if you get this, it could be a dilated cardiomyopathy, or it could be chronic end stage of the valvular disease, chronic degenerative valvular disease, all right? But always, always, always remember to rule out peritoneal effusion, because in any cases of a cardiomegaly, globoid heart shape, peritoneal effusion may, peritoneal, pericardial effusion. Okay, please make correction. Pericardial effusion, all right, would be the differential diagnosis. Okay. round, heart shape, but this one has got a bulge lah. Okay, aorta sits here, pulmonary artery, not really. Pulmonary artery always comes down like that. So this could be a left auricle enlargement. You see the apex of the heart also shifted already. By right, it should be here. Okay, also shifted. All you get is the big round heart. Okay, and then always rule out pericardial effusion. Okay, there are some heart diseases that you're still gonna get a normal heart, meaning you're gonna have a normal VHS, and these are the differential. Okay, and often this is because there is disease progression, but it is not detectable on radiograph, and often these diseases are at preclinical stage, meaning at early stage of the heart disease. So, how do you know that this heart size is actually normal? Yes, you know it's normal, but you need to rely on your auscultation, which is very important. Subaortic stenosis will give you a systolic murmur. Pulmonic stenosis, systolic murmur. Cardiomyopathy, tachycardia. Heart rate is like racing, but radiograph tells you it's a normal heart size. Endocarditis, again, you're going to have a systolic murmur. Okay, so and the differential goes on. Like shunting, definitely will give you a systolic or a continuous murmur. So if you get an abnormal auscultation but a normal heart size, it's okay. Don't worry about it. As long as if you have heard a murmur, you know there's issues with the rhythms and rate, that's fine. It just tells you that this is just at early stage of the heart disease. Okay? Okay. Always remember about the parenchyma, the pulmonary parenchyma, the lungs. Heart disease is always alveolar, but you do have other patterns. This one I'll need you to go and do a revision that you have a bronchiolar pattern, interstitial pattern, or a nodular pattern. Nodular often refers to cancer lah. Bronchiolar pattern often refers to, remember Dr. Lau would say, a donut, perivascular cuffings and stuff like that. So bronchiolar pattern always is more of like chronic bronchitis, asthma. Interstitial pattern, you have the mixed, and you have mixed interstitial pattern, and there's another one pattern that she actually says in the class also as well. So you need to do a revision. Okay. Okay. Cardiogenic pulmonary edema often looks like this. All right. Increased opacity of the lung parenchyma. Fluffy appearance, unstructured. Okay, it could appear in any part of the lung parenchyma. All right, sometimes you can get an abnormalities of the vein. They appear broader than usual. Okay, first stage. So where is perihyla region? This is perihyla to hyla, perihyla, and this is entirely called the hyla. So sometimes you can say, okay, where's the pulmonary edema? Increased opacity of the lung parenchyma at the perihyla region. Okay, because this one still looks normal. Okay, so this is perihyla. And the differential would be pulmonary edema. Okay, second stage of pulmonary edema, often what happens is there's hydrostatic pressure increase, that exceed the plasma oncotic pressure. So you're going to have fluids that goes into the interstitial space. All right, so again, pulmonary edema may looks like this also as well. Okay, your blood vessels are not very clear. It looks very blurring. You're not very sure. This is cranial vena cava, caudal vena cava. And in a very bad stage of pulmonary edema, definitely the alveolar pattern is generalized all over the place. They may sometimes look like interstitial pattern as well. And then you say, Dr. Khor, it doesn't look like pulmonary edema anymore. There's no alveolar pattern. And it looks like an unorganized interstitial pattern. Then yes, that's what happens in chronic stage of pulmonary edema. That's what they looks like also as well. So I'll show you a little radiograph soon. Okay. So pulmonary edema, go back to Dr. Lau's notes. you get these air alveolograms, also air bronchograms. All right. In cats, in dogs, normally the pulmonary edema is perihilar to the hilar region. But in cats, could be anywhere. Cats never follow the rules. Okay, you can have edema in the hilar and perihilar, or sometimes you can have the edema cranial to the heart. Okay, and they're already gasping for air as if they're dying, but the edema was only cranial to the heart. So the distribution can be asymmetric also as well. And often when it happens, it's very acute onset lah. Okay, they may die because of respiratory collapse. All right. Pathogenic pulmonary edema, increased opacity of the lung parenchyma. You can't see the heart silhouette very well. You see the margin, very blurry one. Okay. Interstitial pattern, you can say, Dr. Khor, this is interstitial pattern. Okay, I'm not going to fault you. Can you see blood vessels also? You can't, appreciate very well. Increased opacity of the lung parenchyma, perihilar to hilar region. Okay, and you can see when you do a VHS, you can see this trachea also elevated. All right, if they're very chronic, then you can tell me, Dr. Khor, isn't this like bronchiolar pattern? Okay, yeah, it's like bronchiolar pattern also, but often only chronic end stage will give you this lah. All right, initial stage will not show you this. Initial stage would be only the alveolar pattern. Okay, inverted D, betul? Inverted D, betul? Are you all still there? Betul, tapi salah ha. This radiograph is not square. Okay. Why I say not square? You see, the sternum is here, the thoracic vertebrae is here. So if you put the finger here, if you put them parallel to each other, then you look at the shape. Okay, so this is the sternum, your baby finger is the sternum. This one is your thumb is your thoracic vertebrae. If you follow the radiograph, if you tilt it like this, of course you're gonna get an inverted D, right? The radiograph is not positioned squarely. Okay, so yes, so it's very important lah. Radiograph must be very square to evaluate the heart. Otherwise, you're gonna misinterpret it. All right. Never forget about pleural effusion. Okay. Ini adalah satu statement yang saya dengan Dr. Lau sangat pantang. Alright. You need to identify pleural effusion and pulmonary edema on the radiograph because the treatment are different. The radiographs are really different. Just now, what I've shown you is always cardiogenic pulmonary edema. Cardiogenic pulmonary edema happens in cats and dogs, okay, for cardiovascular diseases. Pleural effusion is very common in cats, could be related to heart disease. All right, when you have pleural effusion in dogs, it is not, dia bukan sakit jantung. It's often related to other sets of heart disease. Okay? You don't come and tell me this radiograph, doctor, increased opacity of the lung parenchyma, and I think this is pleural effusion. This one, I will take a gun and shoot you. Okay? Because the treatment for these cases are entirely different. Okay? Can you see dorsally elevated? Dorsally elevated trachea. Can you see lifting of the lung lobes? Retraction of the lung lobes from the thoracic. Okay. Can you see jantung tak? Can you see the heart? Fluid opacity, tissue opacity, pretty similar. Cardiac silhouette is obscure. These are all the typical description for pleural effusion. Okay, don't look at this radiograph and say, Doctor, this is pulmonary edema. Then I pengsan lah. Can you see the heart? No, relax. Okay, can you see the lung? Yes, but you can't see the lung very well, isn't it? Okay, you can see increased opacity, not actually in the lung, but in the pleural space. Okay, diaphragm also cannot see very well. Right, blood vessel, yes lah, can see. Okay, not very sure, but it's there. All right. Can you see increased opacity? Okay, but it's in the pleural space. Ini kenapa pula? Okay, this one is a lung torsion lah. All right, but this is not a common radiograph that you will get. Okay, this is not heart disease, this is something else. Okay, always remember pleural effusion is common in cats. Yes, one of the differential is heart disease. Kalau if you get pleural effusion in dogs, don't think about heart disease first. Think about other differential. In dogs, it's always pulmonary edema. Okay? Inilah. Okay? Alright? Nobody want to say alright or okay. Okay.
Right, doctor.
Abdomen. Abdomen. Bukan perigi ya. The standard abdomen na. Alright, and I'll show you a development later. Okay? So, if you see ground glass, don't follow this terminology. Often Dr. Lau will say increased opacity of the abdominal cavity and we are not able to see the serosal detail. Serosal detail maksudnya, can you see the intestine? Where is the intestine? Ya, ini saja sikit dia dapat colon. Ini bladder ke? Maybe lah, maybe not. Okay, but can you see the rest of the other intestine? No, you can't see them very well. So loss of serosal detail, the differential will be ascites. Okay? Okay. Now, come, tell me, what do you think about the lungs? Increase, obesity, lung parenchyma, generalize. Hey, nodular pattern. Sajida. Sajida must be a girl. Sajida Amoy. Nodular pattern normally nodular. Nodular, you can see nodules. You can see circular. Okay, we are doing cardiovascular, no, we are not doing onco cases now. Increased opacity of the lung parenchyma. Okay, hyla to perihyla. So I will say this is generalized. All right, can you see the heart? Boleh, can see. Can you put, a line you draw from the carina to the apex? You can see that, oh, doctor, this could be more like a right-sided heart disease. I will say, okay, I don't fault you because you say there's more space. Okay, showing more information on the right side of the heart. Okay, this is a cat or a dog? Meow meow or whoa whoa? Cat. The vertebrae. Big heart, correct? Lungs, not very good, correct? Can you see trachea elevated? And large cardiac syllobate. You do a VHS yourself later on when you're free. You can see increased opacity of the lung parenchyma, quite generalized. Fluffy appearance. Yeah, you don't get the bronchiolar pattern or whatnot. All right, in cats, it will appear like that. Okay, good blood vessels, isn't it? All right, your arteries and your vein. Okay, increased opacity, lung parenchyma, generalized caudally. Then you say highly suggestive of pulmonary edema. Okay, do you think this is a left side heart disease or right side heart disease? Always strain your eye, draw the lines. Right side, left side, increased sternal contact. Okay, this could be a right side. Trachea dorsally elevated. Okay, so this could be a right side. This one, right side, left side. Can you see this dog is actually coughing? It's at end stage of the heart disease. Trachea is actually elevated. Okay, could be a right side heart disease also as well. So in radiology, this world is actually black and white. Okay, but it tells you a lot about the heart, the lungs, and the pleural space. And then it will also allow you to come up with differential, because you will then think about, does the radiograph tells me that this is the lung pattern is associated to heart disease or not? Number one. Number two, and that this heart disease is actually a left-sided heart disease or a right-sided heart disease. So all you need to do is stick to the rules and you start guessing. And we often will always need the echocardiography to tell us what is the definitive diagnosis. Okay? Any questions so far?
Doctor,
Yeah.
sorry, because when doctor was explaining the slide on Oscar, we kind of lost you a little bit. So would it
Okay.
be okay if doctor could, yeah,
Yes. Can you
explain?
see
Thank
Oscar
you.
now?
Yep.
Left and right side. So is this a left side or right side? Can you see that the lung pattern has increased opacity, lung parenchyma, but it looks not more than an alveolar pattern. You get this bronchiolar pattern also as well. So you can tell me, doctor, got interstitial, unorganized interstitial pattern also as well. So pulmonary edema at chronic stage may appear like this also. Okay, so if you draw a line from the carina to the apex, okay, you get more information on the right side. So you can say, doctor, it looks like it's going to be a right-sided heart disease. So you want to recheck, you do a DV view. Okay, and see, ada ke inverted D, or is it there is a cardiomegaly? Okay, globoid shape ke, god shape ke, no shape ke, apex of the heart shifted where? Okay, so often evaluate radiograph 2 views. All right. Other than pancreatitis, okay, I stop sharing first, then I will be able, or somebody want to read out that question? She right there. Other than pancreatitis, other inflammation of the organs will cause heart arrhythmia too. Now, heart arrhythmia can be affected by many differential. Electrolyte imbalance also can. Animal come into shock also can. Many things. Okay, potassium very high, potassium very low. Arrhythmia can occur. Animal comes down with shock, they are almost dying. Arrhythmia also can occur. Okay, so it's not just pancreatitis or inflammation of the organs, and you will get arrhythmia. All right, physiology also can. I'm so scared, my heart rate increased. That one is also arrhythmia. Okay, go back to your definition of arrhythmia to understand. All right, I don't know whether I can finish echocardiography in between panggil apa, half an hour, but shall we continue? I know you're very smart one. I'm sure you'll put some biscuits or whatever it is beside you. Okay, we shall just continue. I see how much I can finish in between half an hour. I will not rush through it, but during practical, we will reinforce back the information. Okay? Okay, what am I doing right now? I should be sharing. Really me share. Share what? Okay, share this. So, okay. Echocardiography, yeah. Now comes the exciting part. Dr. Lau didn't teach you all this. Okay. What does echo gives you? It tells you how big is the heart, how thick is the wall, what is the motion of the wall, okay, is it contracting properly, what does the valve look like, pretty or not, nice or not, or all thickened already, and how the valves are actually flapping, okay. It tells you the ventricular systolic function, the contractility, all right. And sometimes it tells you whether the greater blood vessels are enlarged. So mainly the pulmonary arteries and the aorta. Okay, do they look big or small or stuff like that? Okay, there are many modalities when it comes to ultrasound of the heart. Modalities means Dr. Lau has already taught you, right? 2D, exposed you to 3Ds. Okay, so that what its modality means. So 2Ds, black and white image, real-time images. Okay, you can see the heart, move also as well, each heartbeat and each heart rate, and how do they look like. M mode, normally we will want to measure color flow. You have pulse wave and continuous wave Doppler imaging, Doppler examination, or tissue Doppler imaging. We don't have this in UVH, but I'll show you some images also as well. Okay, every time Dr. Khor is always right. ECG, right lateral recumbency. Radiograph, she wants right lateral recumbency. Similar echocardiography also, I want right lateral recumbency. Okay, so that's how you're going to restrain the animal. So what do you need? Of course ultrasound machine. No ultrasound machine cannot do echocardiography. You need a suitable probe. And this probe comes with different millihertz. So for dogs, it would be suitable to have a deeper penetration. So you need 2 to 7.5 millihertz. And then in cats, you can get away with the pediatric probe, 7.5 to 11 millihertz. Okay? So you need machine, you need probe. After that, you need to shave the patient, right? Dr. Lau will say, you want to do abdominal radiograph, or you need to prepare the patient, you need to shave. Okay, similarly, for the heart, yes, you need to shave for better contact. But for you to have better contact, you need gel. Okay, gel for contact so that you can get the image properly. Don't use alcohol. Alcohol will destroy the surface of the probe. Water is already sufficient. Okay, spray water. And when we conduct echocardiography, often we will connect to the ECG. So sometimes I'm a bit lazy, but theoretically, you need to connect to the ECG, okay, because it's very important for measurement. Okay, but some patient actually hates it. So they get very irritated if you put the ECG and it hurts them. So it depends lah, right? Sometimes I will do it, sometimes I won't. Okay, and of course a table. And you can see that this table that I have in the pictures is already a foam with a cut out area. Okay, and I will use the probe and I will introduce from beneath, okay, to look at the heart. Right lateral recumbency on a suitable table, and often patient will need to be gently restrained, and I don't use anesthesia for this. Okay, cutout tables can come in all shape and size. Most important thing, you need to have a U shape or a V shape, and some institution may have tables. This one, it's the hydraulic table that can be, positioned up and down, but they remove this opening. Okay, and then the echocardiographer will have to approach from the lower side. Okay, dog will be lying on top. All right, so in UVH, that's how we do it lah. So you will join me when you come in for your rotation. Two-dimensional image, two types, right parasternal positioning, long axis. Will give you the 4-chamber view. Will give you the long axis left ventricular outflow view. Okay, two-dimensional, give me two different view. One is right parasternal long axis view, right parasternal short axis view. And then if I want to do another view, 2D also, I can perform a left caudal parasternal position apical view. This particular view will give me 4-chamber inflow view and 5-chamber left ventricular outflow view, which I will show you later on what this view means. Okay. 2D images, right parasternal long axis view. Apa ni, Dr. Khor asyik long. So long means you can see the heart. Long. Okay, long shape. Short axis, I will tell you why. So in long axis 4-chamber view, that's what it means. I can see left atrium, left ventricle, right atrium, right ventricle. Left atrium, left ventricle, right atrium, right ventricle. So same lah, ha? That's what it means lah, ha? One more time. Okay, people? Kalau long axis left ventricular outflow view, you will see the aorta. Ini left atrium, left ventricle, right atrium, right ventricle. You will see aorta if it is left ventricular outflow view. So aorta, okay, and the aortic valve. Aorta, aortic valve. Left atrium, left ventricle, aorta. Okay, I play one more time. Suka hati, I play one more time. Okay, since this is recorded, so you'll be able to view the image many times until to your liking, okay? Okay. Just now I kata long kan? I kata long. Short, you'll see everything circular. Round, 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 round. Oh my god, Dr. Khor apa ni? Image lagi A, B, C, D, E, F. Now, circle in your notes. Important one for measurement, B and E. B and E. This is my true image that I always will quiz you when you come for your rotation. Okay? But how do I get all those image? So just now, I got the heart in very long. I can see left atrium, left ventricle, right ventricle. Now, instead of being long like this, okay, I put my probe, okay, and slice the heart like that. All right, then I get all my image long. So now my probe, I turn it perpendicular. So I will teach you this later in the practical. We will view it. We will view some video, not me talking, somebody else talking, but I will explain later. So the probe is now transected. Then I get everything circular. Okay, so this is the heart, like a hollow. Okay, this one got water. This Ricola. Okay, this Ricola, circular, right? So if I put the probe, it will then transect. Okay, so this particular probe, it will be approached from here. So what I'll do is, I will cut across the structure of the heart, okay, from the base and then slightly go towards the back. So depending on the structures lah. So let's say if you're at the base of the heart, at the apex of the heart, so if you cut the heart like this, then you're just going to get this view. If you cut the image to be B, then the papillary muscles will be visible. Slightly go up, you can see chora tendinase. Slightly go up, you can see the mitral valve. Slightly go up, over here, you actually cut into the aorta. You can see tricuspid valve, you can see pulmonic valve. Anyway, in D, you get your mitral valve. Okay, so when you cut slightly up, you can open up the pulmonary pulmonary artery better, and you can see your pulmonic valve sitting here also as well. Okay, so what it means is apa ni? Left ventricle papillary muscle. Okay, people? So the image will look like this. Left ventricle, papillary muscle. Okay, papillary muscle. Okay, so the image is left ventricle, papillary muscle. Short axis view. This one is when I get the mitral valve. Okay. Can you see like a fish mouth, goldfish mouth, open and close, open and close. If I ask you what is this, You don't tell me this is goldfish mouth view. Right parasternal short axis view at the point of the mitral valve. Then you have posterior and anterior valve. Okay, this is mitral valve. So how I know it's posterior, anterior? Posterior one is here. Anterior one is here. Posterior one is the lower part. Okay? Okay. Right parasternal short axis view. Okay, and this one you're gonna get the aorta and the left atrium. Yeah, you can see my muscle dispense signs, upside down one, muscle dispense signs. If you see that in the middle there is a circle and with this sign, and the left atrium, you know that this is actually at the point of the aorta, where the aorta sits. Okay, aorta, left atrium. This one is actually pulmonary artery lah, there. Okay. Okay, let's see image. Wih, cepatnya. Aorta, left atrium. Pulmonary artery. This one is tricuspid valve opening close here. One more time. Okay, paham? Nobody answer again. All right. Left caudal parasternal apical view. I'm putting the head upside down. So when I do this, just now, right parasternal apical view, right parasternal short axis view. Ini left pula. So when I do this view, the animal will be on left lateral recumbency. Okay, the animal will be on left lateral recumbency. I'll put the probe and angle it in this manner that will slice the heart into half. Looks like an upside down heart, meaning the right and the left atrium would be beneath. Sini. The left ventricle and the right ventricle would be sitting here. So sini apex ma. Apex sini lo. This one base This one apex So this one apex sini. Base of the heart will be here. So biasanya, in this particular view, you can see the mitral valve, you can see the tricuspid valve. Sometimes even if you open up, you can see the aorta valve, okay, which I'll show you later, but I'll show you this 4-chamber view first. Left atrium, left atrium, right atrium. Left ventricle, right ventricle. Okay? Mitral valve, tricuspid valve. Okay. 4-chamber view. Inflow. Inflow 1. Semua perkataan yang ada inflow 1 is refers to the aorta ya. So again, upside down. You actually don't have to learn how to know how to get the image. That one is not day 1 competency. My aim is at least you can identify what all these images means. So 5-chamber left ventricular outflow view. Aorta. This is the aorta. Mitral valve. Okay, let's see video. Video tak jadi. Video tak jadi. Okay. Roll my aorta ya. Okay. Aorta, mitral valve, left atrium, left ventricle. So actually it's practically similar like this lah. It's just that when I open up, I can see a structure of aorta coming out here. Alright, sorry with the video. Okay, how much time do we have? Okay, 20 minutes perhaps. 15 minutes. Short axis, the images that we get is actually time dependent. Time dependent means information you get at this time, this second, this minute. In 1 month time, if the heart has already changed, it will give you a different information also as well. Okay, so when we say yearly screening, what it means that in 2020 on the 31st of December, the heart was fine. That period of time, there were only some mitral valve changes, but all the measurements were great. Perhaps maybe in the future, 31st of December 2021, okay, the images may be different, the structure of the heart has changed, or maybe the measurements have already gone abnormal. Okay, so that's what it means by time dependent. So short axis right parasternal position, you can actually, just now I've mentioned, you can actually look at the papillary muscles, the chorda tendineae, the mitral valve, short axis also as well. You can look at the aorta and the left atrium. And in M mode, we can do measurement of the wall. See how thick is it? The chamber size, is it dilated or is it smaller? Contractility, fraction shortening refers to contractility, whether the systolic function, okay, is good or not. All right, this image will give us the left atrium to aorta ratio, okay, and we can even evaluate the mitral valve motion. So again, just now those images where I say you slice the heart and you get the short axis. Only short axis can give you M mode measurement. Okay, I repeat, only short axis can give you M mode measurement. So you don't do M mode measurement on long axis. Okay, so this one you just have to read lah. All right, let's go to this one, M mode. Okay, this is where it gets confusing. Interventricular septum, D refers to diastole, S refers to systole. Okay? Okay. Interventricular septum, left ventricular internal dimension, left ventricular, P for posterior wall, or some of the machine will give you F for free wall. Okay? It does tells you what is the left ventricular volume, left ventricular mass also as well in an M mode measurement. But most importantly, we want to look at wall thickness, lumen dimension. These are the measurement. D for diastole, S for systole. Okay. Other kind of measurement can tell you what is the ejection fraction that will refer to the cardiac output. Fraction shortening will tell you how well the heart is contracting. Mitral endpoint separation. So this I will go through with you now. Okay. M mode measurement. Normally from long axis tak boleh buat M mode measurement lah. Only in short axis. So everything will look round. Okay. The image where you cut with the papillary muscles, you know, the two papillary muscles by the side, that is the image that you want to get. And when you put a knife, actually not a knife, you put a cursor across the two papillary muscle, one cursor, a line across the two papillary muscles, this is what you're going to get. Okay? This is what you're going to get. Maybe this is the interventricular septum. This is the left ventricular free wall. This is the left ventricular lumen. Interventricular septum, you get this is the right side of the heart. Left ventricle, papillary muscle. So when you put a cursor across the two papillary muscles, you divide them into half-half. Okay, this is the M mode image that you get. This is diastole, systole. Relax, contract. Relax, contract. Systole, diastole. Systole, diastole, systole, diastole. Relax, contract. So diastole, relaxation. Systole, contract. Okay? Faham? So that's how you get this one. Okay, so this one you just have to read through lah. interventricular septum at diastole, interventricular septum at systole. Lumen, left ventricular internal dimension, LVIDD, at diastole, interventricular septum lumen dimension, left ventricular internal dimension at systole. Left ventricular free wall at diastole, left ventricular free wall at systole. Okay, so you just need to play the video over and over again to see what I refer to. All right, so M mode measurement, same law, left ventricular, and as they are contracting, I do all this measurement. Okay, so let's say the internal dimension, the interventricular septum for this dog, the thickness of the wall is 9.9. The lumen dimension at diastole is 28.5. Okay, the left posterior wall, this is left ventricular posterior wall. Sometimes they tap out into LW. They will just give you posterior wall at diastole. So this is what it means. So. Okay, so same. What do I want to do? Okay, so these are the measurements lah. This one I just make the image bigger only. Okay, now M mode will give you fraction shortening, and fraction shortening will tell you how well is the contractility of the heart, and they have a formula for it. Okay, you don't have to remember the formula, but actually it's a calculation of the LVEDD minus the LVESD, this one and this one over the LVEDD times 100%. What is more important for you to remember is it is based on heart weight, the weight of the body weight of the patient. That's one thing. And the contractility may range from 21 to 60. But for me, anything less than 25 in a dog refers to poor contractility. Anything less than 30 in a cat is poor contractility. EPSS, point of septal separation. This is the definition. But when we measure, we are actually measuring, this is the interventricular septum, and this is the mitral valve. Okay, the mitral valve. And when we measure, this is the location. At the point, the white line of the interventricular septum to the tip of the mitral valve is EPSS. So if there's a volume overload, you're going to get a very big distance over here lah. Okay. LA to AO ratio, I don't measure it that way. In some paper, yes, they do this kind of measurement, but this is not a standard measurement. So if you get an M mode and say, hey, kenapa it looks like that? Huh? So you know that they're actually just drawing a line and cutting across the aorta and the left atrium and smear it across and give you an M mode. Okay, but that's not how I measure. I will show you what is the standard measurement. The left atrium lumen for this kind of images is this one. You measure from here to here and aorta will be here. So if I look at this image, the left atrium, I will measure from here to here. Aorta will be from here to here. Okay, so the standard measurement that has been published and worldwide every cardiologist will follow, or every cardiac ultrasonographer will follow, will be the measurement from left atrium. You make a mark from here to here, and then you identify the aorta. You measure perpendicular from here to here. Okay, so this is the distance lah. All right, and they will give you a ratio. So this is what you call left atrium to aorta ratio. So the rule of thumb is anything more than 1.6. It shows that the left atrium is enlarged. Okay, anything more than 1.6, the left atrium is enlarged. Okay, what is Doppler imaging? You only use Doppler imaging where you know there is a valve issue. You heard a murmur. Oh, got whoosh, 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 whoosh in between the lap ducts. all right, or you hear a whoosh, 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 whoosh non-stop, okay, then only you use a Doppler investigation. And they tells you the hemodynamic of the blood flow, okay, and they can tell you the pressure and you can estimate the flow. So basically okay, I need to put this, basically it looks like this lah. So if everything that is normal, it will be just, if the flow is correct, it will be just red and blue. If you see green, you know that there's a regurgitation there. Red and blue, oh, cantik. But over here, you see green. You see this mixing pattern. Okay? So that tells you that, okay, correct. When you ausculted, you heard a murmur. All right. Okay. So this is pulse wave Doppler or color flow Doppler. All right. Pulse wave Doppler, it will localize the flow disturbance and quantify the left ventricular filling as a surrogate for myocardial relaxation. So often, I will do until here lah. In UVH machine, I can only do until this particular image and not really this. And you don't have to worry about this one because this one is often more for research purposes. Okay, so all you need to know that there is pulse wave Doppler. Doppler means got color, and a color flow Doppler. Okay, this is a little bit different. This is pulse wave, color 2D and M mode Doppler, but this is tissue imaging. So just now one is blood velocity, but this one is myocardial relaxation. Okay, so these images often will appear like this lor. You get blue and black, you get red and blue, but this red and blue is actually, the color is on the myocardium. Okay, and then they put a cursor on it, and then they will see whether the myocardium is relaxed or contract properly or not. Okay, that's it. Ngam ngam. 12:59. What image is this? What image is this one? Short axis or long axis?
Short.
Short. What is this in the middle?
Aorta.
Bagus. What is this in the lower part?
Left ventricle.
Hey, salah.
Atrium.
Left atrium. Okay, so LA to aorta ratio, so you measure lah. Okay, you take your calculator. Andaikan I measure this, I get 17. LA to aorta ratio. LA 17. Aorta I get 9. So what is the ratio? So you take 17 divided by 9. What do you get?
1.8. 1.9.
So 1.8, 1.9. So anything that you get more than 1.6, you know that this left atrium is huge. Okay? And then you look at the radiograph. Clock face analogy. Where is the location of the left atrium on a DV view? So you will tell me the core, the left auricle is between 2 to 3 o'clock. Yes, I can see a bulge. Or maybe you say on the radiograph on the lateral view. Lateral view, the left atrium is also the same, 1 to 2 o'clock, and then I can see a bulge there. All right, and then I did a VLAS, VLAS, and I measure Dr. Khor is 22.5. Okay, look, I'll just tell you, right, you're correct, the left atrium is enlarged. Okay, so often whenever we do echocardiography, I will always rely on physical examination finding. Oh, cancel. I will often rely on physical examination finding, very important. Radiograph finding, very important. And your echocardiographic finding. All these findings supports the echocardiography, then only we come up with your definitive diagnosis. You cannot evaluate echocardiography images independent by itself and then just say, okay, this dog is having this problem. Yes, echocardiography gives you definitive diagnosis. If the disease is very apparent, very clear, the information is, gives you all the ticks in the box. But sometimes there are certain diseases or condition is preclinical stage. It did give you clinical sign, but they were not very severe. So you need, information in combination from the physical examination, history taking, radiograph, your auscultation, and then you use in this information in combine of the echocardiographic finding, you come up with your definitive diagnosis. Okay, they cannot be standalone. Unfortunately, they cannot be standalone. All right. Okay, sure. Okay, any other questions so far? Any other questions so far? Only Mira is alert girl and Sajida. Okay. Ravina and then let's follow suit. Okay, so what we're gonna do later, so you're gonna have lunch. Very important. I also need to rest my throat. Ayo, benda ni tak mau move. And dia sangat kacau. Okay. Like, what we're gonna do later? This is already up in Putra Blast. Okay, under the lecture notes section, I've already give you this similar PowerPoint where you can actually click into all these YouTubes that is available below. First thing first, you go and make yourself a good cup of tea or whatever it is. We will view all these videos together and I like them very much because I don't have to talk. You just need to listen to somebody else talking. We will go through this video together. Okay, and I'll explain if you have got question now, you don't understand what she was saying. So we're just going to view all this video as much as we can and the allocated time will be like 40 minutes. Okay, and we'll listen to Mama again. Okay, for those of you who have missed or you felt that, oh, okay, I couldn't get a good connection and I want to listen to it again. And if you have got question, you can ask at this particular slot, 20 minutes. Actually not Mama listening in groups lah, meaning we will do it together. Then I've already put up all